today we're doing an overview of our pharmacology manual, and I'm presenting on Flumazenil or Romazicon. This medication is classified as a benzodiazepine antagonist. We utilize this in an effort to reverse oversedation from benzodiazepines. You may not necessarily see it very frequently in a pre-hospital setting, but it is more commonly used to reverse sedation via benzodiazepine or GABA acting type agents following procedural anesthesia. Things like if you go get a procedure done at an outpatient facility and they want you to wake up from anesthesia more rapidly, they may administer this in an effort to overcome the lasting effects of something like the induction agent that they used prior to sedating, intubating, and performing the procedure. Like if you're going out to get a laparoscopic procedure, you may see this being given to a patient following their ending that procedure. The mechanism of action of this is that it competes with benzodiazepine at the GABA receptor sites and helps prevent and reverse the sedation effects of benzodiazepines. Contraindications, as with anything, are hypersensitivity or allergy. It's contraindicated entirely anytime we're suffering from a tricyclic antidepressant overdose. Anytime the patient is actively seizing, has a history of seizures, or there's a risk of seizures, potentially things like closed head injury, known history thereof, and then anytime we know that a patient has a benzodiazepine dependence. The reasoning for this is simply that once you've administered this, it's sort of like when you administer Narcan, there's no going back. Its half-life is however long its half-life is going to be, generally ranging from, terminal effects of like 30 to 45 minutes, and that no other GABA acting agents or benzodiazepines will be effective. And the risk here is that, as with anything adverse effects we talk about, if they do go into a seizure following administration of this medication, our only pharmacological agents that we normally carry in a 911 setting to reverse a seizure, being benzodiazepines, will be totally ineffective. Other adverse effects are things like nausea and vomiting as they come out of that state, increased dizziness, and like we talked about, you just need to exercise extreme caution if there's any possibility of following administration seizure activity, and that's primarily because it entirely outcompetes benzos at GABA receptor sites, and the only way we can mitigate those is with other benzodiazepines. Our dosing for this is 0.2 milligrams IV or IO only. We give that slow push over 15 to 30 seconds, and this can be repeated every approximately 60 seconds to a maximum single dose of 1 milligram, or obviously the reversal of that sedating agent. Pearls are big things to remember with this is that very few pre-hospital agencies carry this, but you may encounter it in the interfacility acute care setting, or like I said, a lot of times I've seen this used at outpatient facilities following like laparoscopic or outpatient surgical procedures to reverse that sedation when they come out. So you need to be aware is that that's been administered, that it's very likely that if there is seizure events that you're not going to be able to control those through the use of the benzodiazepines we do carry.